I'm so pleased to introduce our moderator for this panel, Dr. Ashwin Vasan, who's the president and CEO of Fountain House, a national nonprofit fighting to improve health, increase opportunity, and reduce social and economic isolation for people with serious mental illness. Under Dr. Vasan's leadership, Fountain House's work has advanced at the intersection of health, mental illness, homelessness, criminal justice, and social welfare for marginalized communities by centering the voices of people with lived experience. Dr. Vasan is going to kick off this conversation and introduce our panelists. So I'll hand it over to him. Thank you so much.
Okay, I hope everyone can hear me. Thank you so much, Bonnie, for the kind introduction. It's a real pleasure to be here today with all of you. Thanks for joining us on this Tuesday afternoon for session 2 of this year's Health and Housing Consortium's annual convening to discuss coordinating systems to improve support for homeless New Yorkers experiencing mental health crises. I'm Dr. Ashwin Vasan. I'm the president and CEO of Fountain House. Over 70 years ago here in New York City, we originated something called the clubhouse model, a model of social infrastructure and rehabilitative supports based on principles of social work and human-centered design, created to improve health and opportunity for people who are extremely socially and economically isolated. Fountain House's model has been replicated more than 300 times around the US and the globe, including 14 replicas right here in New York City. In 2013, we were proud to open a Fountain House location in the South Bronx and have been honored to serve this community ever since, and are in the process of securing funding to build a new flagship site in the South Bronx in 2023. Fountain House is also a provider of housing services ourselves. Over 40% of our members arrive with the current or recent history of homelessness, and we work with them to find stable, affordable housing that we either provide ourselves or through our many, many partners across the city, with over 99% of them stably housed within 1 year of their first visit to Fountain House. We understand intimately how housing instability reinforces social isolation, which in turn worsens health and shuts people out from the services and the supports that they so desperately need. Many of us are aware that New Yorkers experiencing homelessness have higher rates of serious mental illness than their housed counterparts and often have to interact with multiple systems, including police and homeless services providers, mental health treatment teams, and hospitals when in crisis. Throughout this panel, we will hear from professionals working with this population on the street, in shelters, in emergency departments, and in the community, and to explore how we can improve quality and coordination across systems in order to provide better care in times of crisis and in an ongoing way to prevent crises in the first place. The interconnected mental health and housing crises in New York City are a stark reminder of the inequities that exist. And I just want to share a few statistics to ground our conversation in this regard. About 300,000 adult New Yorkers live with serious and persistent mental illness. And 40% of our street homeless New Yorkers live with mental illness, substance use disorder, or other severe health problems. The situation is especially challenging in the Bronx, which has both the highest rate of overall psychiatric hospitalizations and the highest prevalence of people who have experienced serious psychological distress across all 5 boroughs. All of this is made worse, of course, by the pandemic. This is compounded by the fact that 91% of the population insured by Medicaid, for instance, in the Bronx, lives in a mental health professional shortage area, which is a federal HRSA designation, meaning there just aren't enough providers or other barriers to accessing care to meet demand. Homelessness is on the rise across the city, with over 47,000 people sleeping in New York City municipal shelters each night, a number that's nearly 20% higher than it was just a decade ago. And we know that these individuals are more likely to live with serious mental illness. More than 38% of individuals in the shelter system come from the Bronx, compared to about 29% from Brooklyn and 17% from Manhattan. The economic toll is also staggering. It can cost up to $48,000 a year to house one adult in a shelter, and it costs over $500,000 a year to incarcerate them. It's also impossible to talk about a crisis of homelessness without naming the elephant in the room, which is that we have an affordable housing crisis in New York City and in the Bronx. Wages in our city for city renters have stagnated over the last 20 years, increasing by less than 15% after adjusting for inflation. During the same period, average monthly rent for an apartment in the city has increased by almost 40%. This crisis has only been worsened by the pandemic, especially in places like the Bronx, where the current unemployment rate is triple the national figure, and many residents are left wondering if there'll be enough pandemic rent relief to keep them housed. So we certainly have a lot to discuss, and I'm very pleased today to be with our incredible panel of experts, and I'll introduce them now. First, we have Dr. Tony Carino, the Director of Psychiatry at Janie Medical Care and a psychiatrist for people experiencing street homelessness and serious mental illness through the Bronx Works Homeless Outreach Team and the CUCS ACT team. Prior to joining Janian's Medical Care Project for psychiatric outreach to the homeless, Dr. Carino was the Associate Medical Director at Pathways to Housing in New York City. Next, we have Tamara Gale, the Program Director at the Jerome Avenue Men's Shelter at Bronx Works, a 200-bed single adult shelter for men and trans-identifying folks living with severe mental illness. Tamara is a social worker with over 10 years of experience in social services settings, working with populations such as people living with HIV/AIDS, young adults, and people experiencing homelessness. In her role at Bronx Works, Tamara has developed systems to improve outcomes for clients, as well as programs to facilitate placement in permanent housing and engagement in mental health, physical health, and substance use treatment. We also have with us Evelyn Graham-Nyasi, an advocacy specialist at Community Access. Evelyn is a graduate of City College and Burr and BMCC and Howie T. Harp Advocacy Center, and is currently studying adolescent education at St. John's University Graduate School of Education. Evelyn is also a member of Correct Crisis Intervention Today, CCIT NYC, which advocates to replace police at mental health crisis calls with mental health peers and an emergency medical technician. Through her lived experiences, this topic is near to her heart, and she's committed to advocate for change in the mental health system. And last, but most certainly not least, we have Dr. Mitchell Katz, the president and CEO of New York City Health and Hospital System, our public hospital system. Since his appointment in 2018, the health system has significantly expanded access to healthcare, including the creation of NYC Care, a universal health access program that provides care to more than 80,000 uninsured New Yorkers. Dr. Katz is a pioneer of the Housing First movement, launching the Housing for Health initiative in Los Angeles, which used healthcare dollars to get thousands of the sickest homeless folks living in LA into permanent supportive housing and connected to support services. So I want to first thank our panelists today for joining me to discuss how we can best support our most vulnerable New Yorkers in both in times of crisis and every day in their lives. None of us can do it alone, and it says a lot that so many of us have come together this afternoon to make this a priority. So let's start with a question for all the panelists, and it's the million-dollar question, which is, how has COVID-19 impacted those you serve and work for? And it's open to the panel. Anyone can jump in. Don't all jump at once.
I know at Community Access, they haven't been able to do recreational activities or anything, or go online to compute, to courses or just to search the web. And it's been very frustrating for some of them. And a lot of them have been getting depressed, but we're trying to wait on OMH to, let go, release the hold that they have on the living situation because of COVID.
Evelyn, just as a follow-up, how have you seen, the folks you work with and the communities you're a peer of are obviously, disproportionately impacted by social isolation, economic isolation. How have you seen that manifest? It's, COVID has been a time of isolation for all of us to some degree or another. But people who are already isolated by virtue of the illnesses that affect them and the stigma and discrimination they face, what was your experience been amongst your peers and in the programs you work in on the issue of isolation? You're on mute, Evelyn. it only took 5 minutes, for the first technology
I
issue.
work from home. I work from home, so I am isolated from my peers. Me and my coworker, we work together every day, and we've developed a good relationship. So that's been very helpful. Some of the clients, they are able to work with health and wellness to help them alleviate some of the stress that they have. And then you still have those who are, like you said, are isolating. It's been very frustrating for them. And we're trying to wait for OMH to say that it's okay to do things.
Dr. Carino, you're doing a lot of street outreach and, homeless outreach with unhoused folks. Obviously, that population has risen during the pandemic. What's the day-to-day been like for you as you've continued your work and expanded your work during the pandemic?
Thanks, Ashwin. Yeah, I think that we've seen some direct and indirect consequences with the pandemic. First off, we now have a sense that people with severe mental illness, in particular schizophrenia, have 4 times increased mortality directly from the illness itself. And we've also seen worsening of psychiatric symptoms and episodes as we have in the general population, but in particular amongst folks with underlying severe mental illness. I think the other piece to this has been really the psychosocial disconnect and disruption of some of the safety net systems. And so what we've seen is that it's been really challenging for people to access the communities that they have and that they've historically had. And so I think part of this has led to some of the indirect and direct consequences, increase in substance use and mental health symptoms. I think there's been some adaptation that's been helpful. The folks that, where the psychiatrists and social workers and support staff has stuck with people through the pandemic, the bonds and the alliance I experience is really high. We've sort of been with one another together. And that's been pretty intense and positive. I think that there's been a real sort of blending and use sometimes of telehealth, in particular telehealth to the hospitals to coordinate and case conference has been helpful, and with some support staff, in addition to some safe havens and when people have access to smartphones, tablets, and you provide access, that's been a helpful thing for people in addition to and combined with the in-person care that people need. And I also think that sort of having psychiatric support staff sort of on the front line, working with people in making decisions around decisions like vaccination and advocacy around getting physical health care has been helpful as well. So there's been some areas where we've really adapted to try and meet the needs amongst the community.
Just as a quick follow-up, you talked about telehealth. We're all talking about a massive expansion in telehealth to make up for real structural and workforce gaps, to address some of the needs in these mental health deserts and healthcare deserts that we've described across the city. What have you seen specifically in terms of uptake, challenges to retention into telehealth? What are for people with SMI? What do you see as some of the ongoing issues in terms of long-term care? Are there specific functions in terms of care, like initial screening and diagnosis or medication management? Are there parts that telehealth is most useful for in your experience when dealing with the street homeless population, and others where it might struggle?
Absolutely. I think that when this option is offered, it has to be very much integrated in with the program support, and access needs to be ensured. So, for example, on the Bronx Works Hot team, I'm seeing people in person, but then there are occasions when people are moving to multiple different safe havens and even into permanent housing, and the team is able to kind of support, and the folks that we serve have oftentimes smartphones, and so we're able to provide a continuity of care. and also provide care to multiple safe havens, blended with the in-person engagement work and comprehensive evaluation work that's really important. I think the other piece to this is, there's a few people that actually were pretty hesitant to meet with a psychiatrist, and the outreach team worked very closely to kind of work with them. And a couple people we've been able to engage via the work with the case managers, smartphones, and then that led to an engagement that led to an in-person visit and ultimately care and housing on a few occasions. So I think with judicious and thoughtful use, when telepsychiatry is coordinated with the program site and a part of a blended approach, it can increase access. Our experience is that when program sites don't provide the technology, the support, and people are patients are on their own to sort of navigate the system, it tends to not work effectively.
We've had, because I think it fits well with what Dr. Carino has talked about, we've had a lot of success with the show vans. So we started health and hospitals through our COVID testing, started with vans going around that were mostly aimed at providing COVID vaccination. I mean, that was really our goal, and to do COVID testing as well. But we have found that for a group of people who are living on the street, it's an attractive option because it enables them to come in to get some snacks. We provide clean clothing, and then we're able to vaccinate, test. We've had people show interest then in starting buprenorphine. We can then connect them because then we have the technology. Because as Dr. Carino is saying, not everybody has the technology, but then we can connect them in the van to the technology. We can start someone on buprenorphine. We can do dressing changes or hypertension medications. And we found that we've actually, just by going to the same sites over and over again, people are coming to see us like a brick and mortar clinic, except we're on wheels. I have to say, I've been very pleased because I've always wanted to be able to provide medical care to people living on the street, but I have also recognized the challenge, which is there's no privacy. You don't have a sterile place to do dressing changes. And the van has given us sort of like a hybrid ability to bring people in and hopefully connect with all of you on other supportive services for these individuals.
Thank you for that. Thanks, Dr. Katz. Do you have any data at this stage that you're willing to talk about sort of follow up and next steps for these folks in terms of connecting to bricks and mortar care or connection into behavioral health care? Do we know that this is a on-ramp or a gateway into the care system, or are we seeing it a closed loop, or both, and depending on sort of which population you're reaching? Do you have a sense of that after a year?
I think it's so too early for. I mean, we know people are voting with their feet on going, and we've given a ton of vaccinations. We've done a ton of COVID testing, and people are coming back. And I think given the needs of this population. I mean, I've always felt there's never going to be one right place, right? We have to make every place the right place. And that the show vans are clearly working for a group of people. So I think that, as long as there is a group who find it useful, I'm happy.
I think there's some powerful insight here as well from some of the work we do at Fountain House is about engaging people on the street with non-clinical services. So we all know that healthcare is a need, it's not a want, right? People don't want to spend time with their physician. They need to, they must. And so is there a way to package an intervention or partner on interventions where actually, we built a kiosk in Times Square with the Times Square Alliance and Breaking Ground and Midtown Community Court. And it's literally just a place for people to congregate and have a cup of coffee and charge their phones should they have a phone and talk to folks and build social connection. And, you know, it's early days. We just launched it in August, but we're seeing quite good uptake into longer term programs through which, you know, it's a gateway to healthcare, it's a gateway to housing, it's a gateway to a whole bunch of things. And so I think there's some powerful insight here about how we show up for people, you know, taking advantage of a crisis, delivering much needed crisis services as a gateway to get longer term care is incredibly smart by the care delivery system. Is there a way in a non-crisis environment to deliver wants and then to bring needs into the question? I think there's a fascinating set of conversations around that. Moving to, I think what I can only imagine is one of the most difficult places to have been working during the pandemic, which is shelters. To Tamara, I'd love for you to talk about your experience over the last, I guess we're going on 2 years now, and what that's been like, and what are the needs you've been addressing, and what are the challenges and constraints you've been addressing them under. And I'd love for you to speak specifically about coordination with, you know, clinical systems and other support systems as well.
Yeah, so Jerome, Jams, we moved to a hotel in Midtown and very early on in the pandemic, right? So we moved all 200 clients to Midtown. This was a new environment for them. This was a new environment for staff. It was pretty difficult because we didn't know what was going on, what was happening. The clients didn't understand it as well. And we, some people were very reluctant in the beginning, right? However, it was very beneficial to our clients, especially those experiencing severe mental illnesses, because they had their own room, right? They had their own room to be able to support themselves. And we saw a lot of people just do better in terms of their mental health, right? And we saw more positive outcomes in these single rooms or double rooms. But I mean, it came with challenges, right? ACT teams changed how they were engaging with clients. So a lot of things became telepsych, telehealth, right? And we know a lot of our clients don't have access to technology. And that was also, this COVID definitely impacted how we staff, and we had staff, right? Social service staff. So our staff schedule was a bit reduced. So their presence wasn't really here because we were trying to compete with what other programs were doing. So that impacted clients tremendously. And because of that, us moving to Midtown, you know, our resources, we have our resources here at Monty and North Central. We work with the Housing at Risk program very closely with the Monty Hospital close to JAMS. And we kind of lost that support when we went to Midtown. So we were very disconnected. We had to learn the new systems, the new hospitals in the Midtown area. We were on 47th Street. And a lot of times we saw that care was disrupted when we went to Midtown. A lot of hospitals weren't really receptive to us. I had an experience with a social worker where she said, you know, it's your clients that are causing issues in this area, right? So there was just a lot going on and we had to adapt. We had to really use DHS and utilize DHS when it came to getting people into the hospital and getting them treated for their mental illness. Our clients just became isolated from their teams. ACT teams weren't coming out regularly. IMT teams weren't coming out regularly, or FACT teams. We actually had a case, a very high profile case where a client who was engaged in a FACT team and had an incident on 42nd Street. So, you know, care just declined as far as the engagement that clients received, and they were very isolated. But we tried our best. We really focused on trying to get them connected to care. We have an on-site clinic, and we really requested that we increase the psych services and medical services being provided because our clients were impacted greatly by the pandemic. We recently moved back in July to congregate setting, and that move back was very difficult for our clients. We saw an increase in incident and overdoses, and we're seeing things tapering off recently. So we're trying to get them and supporting them and getting adjusted and really focusing on getting them into supportive housing. So it's been very different for us. I think just like Dr. Carino said, when we know that we have the services for the access to technology, like we had to get cell phones, additional cell phones for the program so that clients can call. We had to designate a room so they can, go for their groups, whether it's substance use groups or to connect with their therapist. So we had to get creative while we were at the hotel because of how services changed.
Yeah, I mean, we obviously run some congregate housing sites across the city, but I can only imagine the challenges you faced. That's a little bit more of a controlled environment than what you may be able to do at a shelter, and even if you had to move to a hotel. So, tip of the hat to you, really remarkable. Moving on to, something more proximal to the topic, which is about crisis response. There's a lot of discussion at all levels about reforming our crisis response system, about ensuring that people with mental health needs, acute mental health needs in the community are met with health first responses. In parallel to that, we have new federal legislation coming down the pike in 2022 to establish a new suicide prevention hotline, 988. And it's still unclear, both in places like New York City and beyond that, what the overlap is going to be in terms of actually getting mental health crises diverted and seen by the right sets of responders. We have a pilot program here in New York City called Be Heard, which is pairing EMTs and licensed social workers and mental health professionals to do street response in, I think, a couple of districts in Harlem. And there's good data, at least with the calls that do get referred, that folks are getting met with the needs that they met with supports for the needs that they have in the moment, rather than sort of more punitive approaches. So, Evelyn, you have a unique perspective on this issue, on this panel, both as someone who advocates for people with mental health needs to have health first crisis response, but also as someone with lived experience who's had a traumatic experience of forced hospitalization and is open about that. Can you tell us a little bit more from your perspective about your experiences and what you think, how you think our systems need to be redesigned, both in the immediate in terms of crisis response, but also post-crisis, and what's in the in-between of these sort of acute moments in time? Oh, you're on mute again, Evelyn.
I will start off by telling you what happened to me. I was home sitting on my sofa when someone knocked at my door. And when I opened the door, there were 8 to 9 police officers out there. And one of the officers said that someone called 911 from my home and told him that I had a knife. I was scared to death. So the police officer told me that I had to go with him and to bring my medication. I was afraid, so I went with him. And then when I went downstairs, he asked me if I wanted to get into the police car or the ambulance. And I didn't want to go to jail, so I got into the ambulance. I was dropped off at Bellevue Hospital, where I was then taken into a room where people were screaming and yelling, and I was locked up like animals. I asked the doctor if I could have my high blood pressure medication, and he ignored me, and I was sent back to the waiting area. It was a holiday weekend, which made it even more of a nightmare because nothing could be done until Tuesday. So when Tuesday came around, I was taken up to the ward, and I was not released until 2 weeks later. What I believe is that if the police officer had asked me questions and heard my side of the story, like they usually do when they have to respond to a call, before insisting that I go with him, and that a peer with lived experience was also present, I wouldn't have been taken to the hospital because I wasn't acting violently, yelling, screaming, or throwing things around. I was sitting on my sofa. If I made one wrong move, I could have been shot dead. A peer would have also connected me to the services if I needed any. I recently learned that there was a mental health rule in 941, which states that a police or police officer may take custody and transport to a hospital or CPED any person who appears to be mentally ill and is conducting himself or herself in a manner which likely results in serious harm to persons or others. I did say that I was sitting quietly on my sofa without a knife anywhere near me. I feel it's extremely important that a mental health crisis response includes a peer, someone who's been through a crisis before and can empathize and show compassion to the person experiencing a mental health crisis, not treat them like criminals. Police officers are not doctors, and many of them are not properly trained in de-escalation techniques. Not to mention that their uniforms and ambulances with flashing lights are scary and triggers of past experiences that people have had. Many innocent people, mostly minorities, were killed because the police officers didn't know how to handle a mental health crisis call. With regard to what should happen in between a crisis, I feel we need to educate everyone about mental illness and work towards having it destigmatized, especially in schools, colleges, religious institutions, and the community. We need to provide training programs, college supports, and jobs to promote independence, make sure the person has housing, the doctors, therapists, and fun recreational activities to do. They should also be able to socialize with their peers and others to help them stay well and not isolate. It would be great if these services could be found in one place, like a one-stop shopping store. When I was recovering from my last episode, I dreaded traveling all over the place for different services, and sometimes I didn't go. I know also that some of these services already exist, but they really need to be updated to reflect the 21st century. As far as the hospitals go, hospitals should have a peer on the emergency room staff to comfort and assist the person while they're going through the intake procedure. Peers should be on the wards, especially assisting those who are newly diagnosed with a mental illness. Both of them could work together preparing the patient for life outside of the hospital. I wish I had a peer when I was first diagnosed. I was scared to death to leave the hospital because I didn't know what to expect. Yeah. There were, okay, yeah.
I just want to say how brave that description is, how great it is, and how many people I'm sure listening to your description, feel emboldened by hearing you talk about it and seeing, what amazing work you've done in your life and how you're using your experiences to help others.
Thank you.
Yeah, thank you so much for sharing. That's such a
Thank you for sharing that.
poignant story and an important one for people to hear what it feels like to receive the wrong kind of response at a moment of great need, but you're most vulnerable. So thank you for sharing and being so open about it.
I wanted to add that the hospital staff should have mandatory sensitivity and active listening trainings every year to teach staff how to listen, respect, show compassion, and work with people who have mental health challenges. And they can also provide nicer environments for people, not have things look like the dungeons that were out between the 60s and 70s, because hospitals are not supposed to be jails. Yeah, they shouldn't look like jails either.
Agreed. And, I've only been at Fountain House for a couple of years, but one of the things that struck me the most when I arrived was how beautiful and dignified the place is, and how creating dignified environments for dignified care and dignified services and supports indeed lifts up the dignity of the people we serve and the people who serve them. And so thank you so much for sharing that. Dr. Carino, you're out on the streets, you're meeting people all the time in need. You're often at this moment when you're meeting people in crisis or peri-crisis. Tell us your perspective, from the street clinician's perspective, on our crisis response system and where you think it needs to go, and what are some of the challenges you've faced.
So I wanted to thank Evelyn for sharing that. Both your policy recommendations and your lived experience are quite powerful, and I do think that the work on the street is reflective of the wider community. The first aspect of the crisis is like what happens before the crisis, and really what we're suffering from is access to care issues. And one of the sort of approaches we try and take at Janian is to have the psychiatric care embedded into the community as part of a program, as part of a drop-in, as part of a soup kitchen work, really to try and get psychiatric care out there. But access is extraordinarily important in the first place, and access to care that's really empowering is essential. I think that some of the, when someone's sort of in crisis, quite often there's some concrete issues that are happening that oftentimes of the population, the communities I serve, it's about some issues surrounding benefits or housing and some really objective social issues. And really there's been a change in what's going on with the person, and related to one of those challenges. And so I do think sort of building robust services of safe havens and housing is really key. And I think one of the things to kind of sit with a person in crisis is to try and sort of understand what their experiences is, and if they do need emergency services to be with them. Oftentimes the advocacy might be that if I know the person, I ask them about their preferences, where they would want to go if they were in crisis, and do our best to really respect that, so that they can get the care in the setting and with the medications and supports, and contact the people that they want contacted. But also part of the role sometimes is also advocating that, the responders or if the police respond, that the person's going to get the care that they need and be treated safely. And I think Evelyn's concerns about safety are really important. And sometimes the role of the team, of the social worker, of the psychiatrist, is to advocate that the person is treated safely and gets the care that they need. And then the continuity piece, that it's not just about sort of helping someone access crisis services in an emergency room or in another setting, or a diversion center, but really the continuity that there's a communication about what's happening with the person, coordination with the emergency room services, and a real communication. We oftentimes will go to the emergency room to follow up, have multiple phone calls, and coordinate with the inpatient unit by going there or having video conferences. And oftentimes people, when there's a coordinated care plan, they can have a reduction in the crisis services. Like when, medications and support plans are appropriate for somebody experiencing homelessness, they can decrease the crisis in the future too.
So that's a great segue into my next question, which is to Dr. Katz, but to really all of you. We often talk about crisis response in these acute episodic interactions, and how those acute episodic interactions need to change. And Evelyn so eloquently pointed out some very concrete steps that need to change. The inclusion of peers, the different kinds of trainings, and the composition of teams that meet people in crisis. I think there's plenty of data, whether it's from Cahoots in Oregon or the emerging data from here, that needs to be the ethos. But crisis is indeed just a moment in time. And there's a whole intervening series of potential opportunities or systems failures, gaps in the system that can predispose someone to having another crisis, or conversely, avert the next crisis or decrease the frequency of crises going forward. So, Dr. Katz, when you think about all of the structural issues in mental health care in our country, in our city, the lack of access to care, 1/3 of Americans don't even have mental health care when they need it, disproportionately affects the poor, low-income communities, and rural communities, of course. You've got issues with payment and parity that are draining billions of dollars out of what should be a much more robust mental health care system. And of course, you've got, as a result of those longstanding issues, workforce issues, gaps in care, and an absolute shortage in frontline mental health care workers. What is the role? The safety net system is often left to pick up the pieces of those structural failures. What do you see as the role of your safety net system and the safety net systems you've worked in over your career in trying to fill some of those holes, in structural holes created by bad policy and inattention, in stitching together a system of care that gives people the kind of access and can be a gateway to further supports, whether it's through discharge planning or otherwise, the long-term ambulatory care and integrated health care that they need in communities as a crisis preventive and as just good care. How do you see that dynamic play out? It's a challenging, as I think about your role, putting myself in your shoes, I just think that's an incredibly challenging position to be in when you've got these massive structural deficits in the behavioral health system.
Sure. Well, I think a great start, and something I've been thinking about for New York City, where we're lucky and we do have some resources, more than many communities, is how great it would be if the mental health system were a true primary care system, right? Everybody, deserves, someone like Dr. Carino who knows them and can coordinate their care regardless of what setting they're in. It doesn't mean that he would be their doctor when they were in the hospital, but as he was explaining, what he does do with his clients, but is not what is, the broad system for everybody, is coordinate and be involved, right? As a primary care doctor, my patients email me, they text me, they call me. When they're in the hospital, I don't take care of them in the hospital, but they call and tell me I'm in the hospital, and I talk to their hospital doctors. And so, what I would really love to see is, that every person with a mental health issue has, a clinician and a peer and a social worker, and that they form a team, and that team, takes care of them regardless of whether they're in a shelter or in a hospital or at Rikers. They're always connected to them. I think that you would see such a decrease in expenses, because hospitalization, such an expensive proposition. And when you think about it, it really makes no sense, because you provide people with 24-hour, 7-day-a-week intensive care for usually something like 4 to 14 days. And then you release them to, best case scenario, a visit with a case manager the following week for 40 minutes. It's too big a step off for most people. There needs to be more of a plan that is your plan, regardless of where you're seen. It's followed at the shelter, it's followed at Rikers, it's followed by your community-based provider. Everybody knows who your provider is. Everybody knows what the plan is when you have a relapse. And I think, again, this would never work in many rural areas, as you've said, in many areas of the country. But New York City is progressive and does put more money into our mental health system. But as Evelyn has talked about, that doesn't mean that it's really what we want it to be. It's expensive and not particularly, from my point of view, client focused.
And so as you think about how to reshape frontline mental health care in the ways and supports in the ways that you're describing, just from a kind of policy perspective, it's either savings on one side or new dollars on the other. And in my world, I hear the sort of Medicaid waiver sort of trucked out and waved in front of people's face and said, this is the solution, and these are new dollars, and these are new incentives. And I think they're right. There is some really good stuff that's potentially there to be built. As you think about the New York State Medicaid waiver, the application that was put in and hopefully will get approved, what kind of services and it has a focus on high cost, high need, so to speak, complex populations, all of the administrative jargon that we use in healthcare systems and health policy. What kind of attention and how do you think we could pay for it under a waiver like that to build the kind of infrastructure you're talking about, or to redirect the infrastructure to work in the ways that you're describing?
Well, but again, I just want to say I'm not big on acronyms, and I'm not big on talking heads. What I'm really big on is, thoughtful clinicians like Dr. Carino and Tamara, who's a social worker, and Evelyn, who's an advocate. And that if you put together the right group of people and you say, these clients, they belong to you, and you work at taking care of them regardless of where they go, and we will take the pool of mental health money and we will divide it so that the money follows the client, and that it's always the same system, and clients can change. You should always allow for, choice, but that, assign each of the clients, or let clients choose which community-based organization or hospital-based program they want to belong to. I think you will see the savings. I'm in favor, where I think the waiver can help us is on the services that Medicaid doesn't pay for without a waiver. So I'm interested in the waiver paying for emergency housing. I know Kelly Duran is on the call, and this has been a big issue for her, right? Many of our patients who have mental illness or serious medical problems, they really can't make it in a shelter. The shelter, right, they have needs for personal care. They have to have their own bathroom. I mean, it doesn't work. And so a waiver could pay for that. A waiver can pay for, food. A waiver can, pay for other supportive services. Someone put in the chat that lots of times the hospital people don't speak to community people. I think it is a problem, but again, it's our own creation. We haven't created a single, system of care in New York City. We haven't said that these clients belong to Dr. Carino, regardless of where they are. That's something we can do, and I think that would change the dynamic, because everybody would know, just like when a patient appears in the hospital and it's my primary care patient, it says right on their label, Mitch Katz, primary care doctor. We need that level of system.
I don't know, I've seen it not work, right? So here at JAMS, we have Care for the Homeless, and our clients are connected to a provider, and that provider may reach out to the hospital, and the hospitals aren't really responsive. The IMT and ACT team providers reach out to the hospitals and they're not responsive, right? So sometimes it just doesn't work when a client is connected to a treatment team or a medical or psych provider. I've called hospitals and I've got blatantly, ignored.
But Tamara, that's and I think it's great you're saying that's the mistake. That's not the mistake of the model. The model is right. The response you're getting is wrong.
Right. Absolutely.
The model is
suffer.
right.
Yeah, and then our clients suffer when that happens.
Yes, I agree.
Yeah, I mean, I hear you, and I think that there have been attempts to create better models and to define better models. I think there are layers upon layers of bureaucracy and administrative and funding fragmentation that are driving programs and that are driving decision making and that are enforcing silos of care and enforcing silos of systems. And I do think that in addition to thoughtful, clinically focused, socially focused care and definition of new standards and new models of care, whether it's a behavioral health home or if we want to be a CCBHC city or whatever it is, we just need to decide and show that it works. We also need to create new funding mechanisms to actually pay for it that break down some of this separation. Because right now, if you asked anyone doing policy analysis to tell you where the dollars sit for behavioral health care, I mean, the list would be too long to print. It's everywhere. It's hidden. It's visible and it's hidden. It's integrated and it's siloed. And we've got to really think about it in a, some smarter people than me that understand government contracting really need to take this on upstream as at the decision-making level. So I think that's right. I want to ask the question about something that I certainly have learned over the last few years and see very clearly in the lives of the people we serve, the thousands of people we serve at Fountain House, is that we talk a lot about healthcare and we talk a lot about housing. And make no mistake, those are the sine qua nons of recovery. You need to be stably housed. You can't recover on the street. I have yet to hear of anyone living in recovery on the street. Dr. Carino, you can correct me, please. Please correct me if I'm wrong. But I think that housing first and a whole lot of data would suggest otherwise. Especially for people with clinical SMI and untreated SMI or undertreated SMI, clinical care is a sine qua non. But we don't often talk about isolation as a set of symptoms that we can intervene on. We don't often talk about social isolation as something we can break by building social infrastructure, by building opportunities to congregate and to come together in community. And we certainly don't talk about social isolation as a keystone factor in durable engagement into care or housing, or at the very least, the dynamic between isolation and your ability to engage in care, between isolation and your ability to stay stably housed. So how do you think about that problem, Dr. Carino? You see folks all the time who are not adequately treated or undertreated or untreated. You see people who are unhoused. Those two basic levels of the hierarchy of needs are not being met, but they're also isolated on top of it. And what's clear is that medication alone will not break your isolation, and housing alone can actually reinforce your isolation. So what is it? How do you see what's the missing piece here in our community mental health system? What are the kinds of things we need to build? We have models like Trieste in Italy that are trying to break isolation throughout the entire public system and throughout the entire community. May not be realistic in New York City, but what's missing from our community mental health system that we need to start regarding as, more than just projects, but actual part of our public policy solution and health policy solution?
It's a really important and essential question, and I think the human and personal experience, that connection is the piece, right? Is that sometimes we can get swept up in sort of thinking of big data around medications and visits and efficiency and ultimately folks are in need of the human connection. And that's, I think when we think of our resources and our most valuable resources, it's a person connecting with another person. And when we can foster that, folks experiencing chronic homelessness that have really valid reasons to not accept, not trust, to not sort of connect, you need that connection, that human connection. And so, we tend to think of like multiple engagement visits, right? Like where you're meeting with someone for these brief encounters and really connecting with them over time. And I've had the experience of, working on engagement for, 3 to 4 years to help someone sort of feel a little more connected over time. I think the programs and systems and teams that foster that really do well. Some of the intensive mobile treatment teams that can sort of get out there and provide this long-term, but also really effective engagement work can really help and really sort of provide this continuity of the relationship throughout the course of that person's travels from street to home. I think the other piece to this is that, you know, my experience is oftentimes people, when they're disengaged, are potentially very well connected to the community. The folks that I meet with in the Bronx have family members, have people that really care about them that are blocks away oftentimes from their street locations. And so as people kind of develop a little more trust, might have some more stability with housing and treatment, they're oftentimes reconnecting and being reintegrated back to those community connections. And I've always been impressed that I look back at some of my initial encounters with folks, and a couple of years later, they don't have anyone for social support, but they were there. And if we can foster those connections, it's really important. I think the relationship is so essential, and the support services that build on that and that foster that, that's what we need more of.
Evelyn, over to you. Do you have a thought on your own experience and what you felt was missing, your own experience of isolation, and what was missing for you as you went through your journey of recovery? What do you wish you had access to, whether it's a program or a person or a relationship? Are you willing to talk about that for us?
Yeah, my family was very supportive of me and my cousins, and I was working and going to school, so I was able to socialize. However, my son moved away, my daughter moved away, and I was alone. So I felt that I needed to socialize with someone on my level, my peers, and I joined the Fountain House. So that helped me realize that I needed someone to talk to. And I was glad that I joined the Fountain House, because there are people from all walks of life that I can relate to. So I did do something about it. I didn't allow it to take over. Yeah.
That's wonderful to hear. I mean, there's just thousands of stories I've heard in my short time there. And part of what we're trying to do, Evelyn, is to make it legible to other people, so that there's more opportunities for folks in your position to connect with a place like Fountain House. It's just too rare at the moment. It's just too hard to access. I don't know how you heard about it, maybe word of mouth, but you know, that's kind of how people get to those programs, and we have to sort of change that. And I think that gets me to my last question before we start to take some questions from the audience, and I'll go full talking head here. You know, it's a mayoral transition, and it's a time for us to think about what we would ask and demand in some cases from a new administration, and what our hopes are for change. Tamara, what would you be asking for, or what would you like to see the incoming administration address, either in terms of programs, policy, both, as it relates to people with serious mental illness and people experiencing mental health crises and the folks you work with in your shelter?
Yeah, so thinking of one of our challenges here is housing, right? We really work towards supportive housing, and there's just not enough supportive housing, especially for people that either have a history of substance use or are actively using. So when we submit 2010Es, one of the barriers is when a client gets a certain category or approval, there's not many opportunities for them. So they stay in shelter, they're stuck here in a sense, and that really causes them to decline. So I would say more supportive housing for clients, more ACT teams and IMT teams, because when they work, right, and they're connected, and that relationship building and forming and rapport building happens, and we see and they follow clients onto supportive housing, then they have great outcomes, right? Clients don't return to shelter. They're doing really well in supportive housing, or if they go into a scatter site type of housing, they're also doing really well. So I think if we can have more ACT team, more IMT teams, and community supports, that would be extremely helpful. And I think it worked in a way when clients were in single rooms. So maybe if we can consider, reducing shelter sizes, right? Dorm sizes and maybe having more, but it also leads to, we want clients to be housed. I think that would be something that I would request, right? So definitely more supportive housing opportunities, definitely more IMT teams and ACT teams, because there's not many.
Please enter the group number.
And then also just a reduction in shelter size.
Thank you so much. Tony, can you answer that question? Dr. Carino?
I mean, I think Tamara's recommendations are just so right on in so many ways. And, I think in addition to sort of building robust supportive housing, it's also to just allocate resources for mental health care embedded into the supportive housing. When folks were able to support folks in moving into supportive housing, when those housing models have psychiatric and clinical practitioners and primary care practitioners embedded into those housing models, the effectiveness is so high, and the continuity of care is really high. I think that the IMT model has showed us that a lot of the folks that have touch points in multiple institutions can do really well if you have a team that cares about them, that knows them, that follows them, work with them and stay with them. And I think that building on those community resources are helpful. I do think that the health and hospitals complex care clinics like at Woodhall and Bellevue have been very helpful as well. And we've noticed real benefits in terms of care and coordination. And so when we can sort of find common ground between the community-based resources and institutions, we've had some really positive outcomes. So I think ways that we could build that bridge can really help us sort of moving forward.
Okay, over to Evelyn.
And by February 2020, 5.3 million of taxpayer dollars were spent to train police officers how to handle someone who's going through a mental health crisis. Yet 15 out of 18 people experiencing a mental health crisis were killed by the police. The organization that I'm a steering committee member on, Correct Crisis Intervention Today, it's an organization that's advocating for non-police response to mental health calls. We believe that we should have a non-police response to calls. It's a model based on successful Cahoots program in Eugene, Oregon, and we would like to talk to the mayor about that. They do have the Be Heard program, but however, the Be Heard program does not include peers, and you need peers to help with those who are experiencing a mental health crisis. You also need peers in every aspect of anything I feel that has anything to do with a mental illness. So if we were to talk to the mayor, that's what we would talk about, and we would be willing to work with him on that level.
Thank you so much. And clearly the licensed, peer workforce has to be invested in, especially as we talk about these massive structural deficits in our mental health workforce. Investing in peers delivers results. It delivers results in crisis care. It delivers results in retention into care, and patient-reported quality of care. So I couldn't agree with you more in terms of investment into the peer workforce. And I won't ask that question of Dr. Katz, given his role. So it is 4:07 and mindful of time, I'd love to take questions, and we've been getting questions in from the audience. And so I will put some of these to the panel. And so if you can all unmute and just jump in with an answer. First question is, I love the idea of these coordinated plans, but some clients do have a version of this type of plan in place with IMT and ACT teams or ACT teams. What about when hospital staff are unwilling to work with these teams, clinicians, and social service providers who advocate on the patient's behalf?
I can start. Well, first, you said you were going to ask, but I'm a huge believer in peers. You can ask me that anytime.
Oh, I'll ask you that. I didn't want to ask you the mayoral question.
Oh, I see. Okay. Well, I would tell the mayor that I'm elected. I'm a huge supporter.
Huge supporter
of
of peers.
I think
Got
it
it.
makes a big difference. I think that the issue of hospital providers who are not listening to community providers is a cultural issue that we can fix. I think it's just that they're not used to it. They don't understand it. They haven't had enough positive experiences in the past. They're worried about HIPAA, not recognizing that clinical teams are allowed, with the permission of the client, to talk to one another. The only other thing that does happen sometimes is there are times I've often got involved in some of the most challenging situations where a client may not actually have a mental health problem, but may have a serious drug addiction, may have an oppositional personality. People want the person in the hospital, feeling that the person is dangerous, but it poses a problem for us because psychiatric wards are for people with serious mental illness, not for people who have serious drug addictions, but don't have an underlying mental illness. And so sometimes there can be challenges, but I think those are the rare cases, and that everybody would benefit from working more closely together.
Yeah, I think that's completely consistent with my experience. I still see patients in primary care clinic once a week, and we're often the intermediary between hospital staff and not only community-based providers, but even social workers, non-hospital social workers that work in our clinic. And so I do think it's cultural. I also do think it is a fundamental misunderstanding of the role of healthcare in people's lives. And that is cultural. That's also education. It's the way that we bring people up in medical school and otherwise. And so I think we have to really think about the way we're training clinicians and understand their role, that people have a whole set of other needs that have nothing to do with healthcare that actually might dominate their lives much more than their interactions with healthcare. And so when they're not engaged in healthcare, it just worsens their ability to do the thing that's most important to them or most needed at the moment out in the community. And so I probably, like Dr. Katz, I spent a lot of time in HIV clinics when I was a trainee. And that model of HIV comprehensive care, it was always remarkable to me that I, as the physician or the trainee, I knew my role in the room. The person who knew most about the patient was their care manager or their nurse or their social worker. And everyone else that person sat at the head of the table to really drive the care plan. And we did what we needed to do. We tweaked the meds and we wrote the orders. And I felt like that was a clear embodiment of a person's experience in the world, which is that they need a place to sleep and they need stable access to food to take their ARVs in this case, and a whole host of social needs that were impacting their care. And so I think we need to do the same for people with serious mental illness. We need to break down some of those barriers in understanding, and we've already done it before, so it shouldn't be new for clinical medicine to do this. But
it isn't new. But just to connect it with your earlier point about the underfunding of mental health services, we were able to do it because the CARE Act, and Nancy Pelosi gets a huge credit, provided funding for non-medical services through Ryan White Care. And so we had housing and substance treatment and mental health and food and childcare. And so we could be doctors and have people attending to the other needs. In this case, it's the opposite, where the system is paying for the hospitalization, but nobody is paying for the things that would prevent the hospitalization. And part of our challenge is to figure out, how we advocate for the right set of services for our clients in the way you're speaking.
Yeah, agreed. And I think that this is where people are hopeful of things like the 1115 waiver, paying for different things. We'll see. Question to the group. it seems like there can sometimes be a disconnect in expectations about what warrants an inpatient psychiatric stay. The bar for inpatient admission is extremely high. And so sometimes people are sent by outreach teams or others to hospitals for admission or treatment. And these patients are quickly discharged back to the same situation, either without any admission or a very short admission. How can we fill the gaps to get everyone on the same page about what constitutes needs in these situations? Dr. Carino, do you have a perspective on this?
Yeah, I think it's a really important question that we deal with kind of on the ground quite often. And there are some clear, bright lines that we're aware of when people need acute psychiatric inpatient care. And there are times where people are in crisis and they might not need inpatient treatment. And so understanding and thinking through, taking a pause a little bit to help someone get to a safe place acutely, but also thinking through what are the next steps. So if that person does end up in the emergency room, then what might be the helpful long-term outcome there? What are the next steps following that trip to the emergency room? I think sometimes we think in terms of this behavior is concerning and dangerous right now, and then to the ER, but then what, right? And so sometimes I think that sort of exercise, when you can do it in the moment and you kind of think through as a team and you're moving, you might come up with different approaches. Like, for example, sometimes people might benefit from long-term inpatient hospitalization, and that's something that the team would communicate and coordinate with the emergency room around. Sometimes people would benefit from diversion supports or an emergency room visit, potentially with an assessment for a specific issue. Are they in physical health emergency? And if not, then what's the next step that could really help them? There's times where there's areas of collaboration where sometimes people might need a few hours of an assessment or a really important assessment, but then they could sort of move to respite, for example, or may even go to respite beforehand. So I think one of the things that is helpful is to sort of I think sometimes we just think, okay, or teams might think, okay, they're in the ER and then it's solved, right? But oftentimes we have to kind of take the long game and the long-term approach with folks.
Dr. Katz, do you have a perspective on that as well?
I think Dr. Carino did well at explaining almost all. I'll add that there are sometimes there are people who actually improve when they arrive in the hospital, because especially if they have originally been found on the street, right? So you put them in a safer environment, give people food if you have a positive clinician, and they then are 4 hours later, 6 hours later, somewhat different than at the moment that the first person saw them. And so sometimes that's another source of false disagreement, because certainly for involuntary hospitalization, people understand that there is a legal standard that has to be met. I think, as Dr. Carino says, there are those people where it's very clear that they should be in a hospital, those people it's very clear they should not be in the hospital. And then there is this middle group where it's not always clear and where different clinicians can differ, and where sometimes really the issue is what is the best place for this person, and sometimes we don't have it. And then everybody wants the person in the hospital because, well, they're too dysregulated for shelter, or right. And that may be a completely true statement, but to the hospital psychiatrist, that doesn't equal, okay, they should be in the hospital.
Yeah.
Right. It's the question of what is, and that's why I like that Tony talked about respite beds and other, right? We need a broader choices than street, shelter, inpatient hospitalization. Those are not a sufficient number of choices for the people that we are taking care of.
And
I just
please.
share. But even thinking of when I call a hospital and try to coordinate, right, for a client, I had one client that was sent to the hospital multiple times in like a week span. And the hospital wasn't even open to explore with us what was best for the client, right? Unfortunately, the client was transferred from our site, but if we probably coordinated together, the hospital social workers and the team, and then my team, to figure out what would be best for that client, he probably would still be here and then be connected to care. But sometimes hospitals just aren't open to working with us.
I understand.
It happen a lot.
And, you know, they're
We have
facing
to fix that.
they're facing a pressure of closure of psychiatric beds across the city and across the country. And so it's now become an even more scarce resource.
Yeah.
I wonder, I don't know that anyone's tracking this, but I wonder whether that has led to a quiet change in the inclusion criteria here. You know,
Well, it kind of has to.
Yeah, it has to.
Ashton, I'm just speaking of
Scarce
the health and
resource.
hospitals. We're not. I don't feel under any financial pressure, but I have real workforce issues at the moment, especially around psychiatrists. Identifying psychiatrists who want to do hospital-based medicine is hard right now. And it's not about money, or at least it's not only about money. And while we don't change our standards based on how many psychiatrists, if there's no bed, there's no bed, right? All you can do is have the person wait in the emergency room until there is a bed. And I can't open more beds than I can recruit psychiatrists.
Yeah. Switching gears a little, this is a question that comes in for Tamara. As in your experience, has New York City been adequately isolating people experiencing homelessness who test positive for COVID in non-congregate hotels or other individual rooms? And if so, for the folks you work with, how have you all ensured that behavioral and mental health services are available and accessible to those folks who are being isolated in these city or state-run non-congregate facilities, isolation facilities?
Yeah, so I mean, the isolation facilities that we send our clients to are coordinated through Department of Homeless Services. So unfortunately, when we did the move back, a lot of our clients did not come with us. They went to reasonable accommodation sites. And what we learned was that a lot of these sites did not have social workers present, maybe didn't have case managers present or housing team. So my team was still very much involved in supporting our clients, but there was definitely a gap. And I think it talks to the fact that the city really kind of rushed the return back to congregate setting and didn't plan that appropriately. So I hope that answers your question. There weren't many resources and support teams available to the clients. And a lot of my site, we had to stay engaged and connected to our clients to make sure that they got some level of care. And those that were connected to the psych provider on site or medical provider, they lost that because they were transferred to a reasonable accommodation site.
Question for Evelyn. Thank you for that, Tamara. Question for Evelyn. How can people support the advocacy of CCIT NYC?
Sorry, this is something. Okay, if you would like to support CCIT NYC, you can always go to info@ccitnyc.org. Again, that's info@ccitnyc.org.
Thank you so much for sharing. Question for, I guess it'd be Dr. Katz, but I'm sure Dr. Carino and others can weigh in. I've been on the receiving end of this as well. Why aren't there better data sharing agreements between health and hospitals and DHS to better coordinate care for high-risk homeless clients? Workers Connect is rarely helpful, says the questioner.
I don't have a detailed answer. Steve Banks and I work great together. There are, I think, a set of unhelpful HIPAA laws, anything can be shared if someone has signed a consent. Mental health information is appropriately very much protected. but sometimes protected from people who are trying actually to be helpful. And nobody has completely figured out, the answer to that question. But I think it's a good project to work on.
Since
just to kind of
yeah, Tony,
piggyback on,
please.
just to piggyback on that, I think Health and Hospitals has added a great deal of value by sort of allowing for access of Epicare to a lot of the community psychiatrists. So my team now is able to access lab work and some of the imaging and understand what's happening when someone's inpatient through Epicare. And that's been extraordinarily helpful, even if just to know who the attending or the resident is that's taking care of the patient. And there's been a couple times where my team members have like sort of seen something or caught something because we know folks for years and we're able to intervene by coordinating with the hospital. So I do think that the access via Epicare has been extraordinarily helpful, and maybe it could be a model for the future or further collaboration.
Thanks to your staff and team for doing that, Tony. That's really a great help to us.
Thanks for giving us access.
I think it's the last question. We're running short on time. This is to Evelyn and to anyone else who's interested in answering. Since the city is against peers responding to an ED call, what about having the peers join additional training while on the team to qualify them as opposed to opting them out for another social work? Does CCIT have a position on that?
CCIT believes that peers should be the center of practically everything in regarding someone who's having a mental health crisis. We have been advocating. We've been somewhat successful with the Be Heard program. However, they are not allowing peers to have anything to do with it regarding the planning stages or anything. So we're still advocating for that. Yes.
I'll just co-sign that because we're running a park outreach program in Fort Greene Park with New York City Parks and with a few other nonprofits, but also working with the police department to train them on how not to respond, and how to, and peers are leading all of that work. And some of the best feedback we're getting on the quality of the training and how much folks have learned is from our peer trainers. Clearly we need to take it the next step and beyond training and to actual practice, but I think it's a good suggestion right now to ensure that peers are a part of all the training. There's a late breaker question for Tony. What works well in providing mental health support to your patients experiencing street homelessness, and how can we build on it?
Well, I think that first off, empowering someone to have decision-making around their treatment and support plan is extraordinarily important. People experiencing street homelessness oftentimes are disempowered by the structural system surrounding them and the community that has kind of turned their backs on them. So I do think that sort of providing care in a meaningful relationship, but also offering someone the options for treatment, and that goes for psychotherapy, medication approaches, other types of approaches is really, really important. And thinking through the long-term support plan for the person. If I'm sort of engaging someone and they can choose their treatment approaches with a shared decision-making model, they're more likely to kind of connect with me, to follow up, but also to have buy-in with their treatment plan. So that's really important and essential, I think. The other piece to this is to really integrate it into the psychosocial support that housing, benefits, employment, connection to family and community is all part of it, right? So when it's integrated in that way, it has more meaningful outcomes. I'm not going to address somebody's chronic homelessness and the major issues in their lives with an increase in Haldol, a couple milligrams, but if a support plan is integrated into their treatment and their support, people get better and get reintegrated.
Thank you so much, Tony. And I think that's pretty consistent with the way that, even programs that are non-clinical like ours, or have framed themselves as non-clinical like ours, have engaged people, which is centering people's decision-making, doing the basics to build trust and to keep showing up for people. And that goes a whole long way. So I'm going to call time on the session. This has been a really lovely and important discussion. It's not only important to me personally as someone who now works in this space, but as a loved one of who has seen family members suffer crisis and really was left wanting in terms of a response and not knowing what the responses could be. To know that there are so many good people thinking about and working on reforming the kinds of systems and supports we have for people experiencing mental health crises gives me a lot of hope for the future. And so I want to thank the panelists, Evelyn, Tamara, Dr. Carino, Dr. Katz, for your time. I want to thank Bonnie and the consortium for hosting us in this discussion. And I want to wish everyone who participated and listened in and put in great questions. I want to thank you for your time. I'm wishing you all a happy holiday and a safe and peaceful New Year.
Great. Thank you so much, Dr. Basson, and to all of our panelists. This was such an important discussion, and we really value all of your expertise and sharing your thoughts as we try to improve our care system. I just want to give a quick plug for our agenda tomorrow. We'll start back at 12:30 with a keynote from Daryl McGraw, founder of Formerly Inc. And then we'll have a panel titled Close Records, Then What? Ensuring Appropriate Healthcare and Housing for Individuals Leaving Incarceration. We'll have a little break at half an hour. And then for session 4, we will have a presentation from New York State Medicaid Director Brett Friedman on the Medicaid waiver concept paper that was brought up in this discussion, and a really lengthy Q&A. So it's a great opportunity. If you have questions about the paper and the process, please be sure to join us, and then we'll have some closing remarks. So thank you all again so much. We hope to see you tomorrow and have a wonderful evening. Thank you.